what I'm going to do is actually just facilitate the conversation for us to have another weekly update on our Odyssey Phenotype February activities. This week we saw 7 great conversations get started on the Odyssey forums, and I want us to be able to, for those who missed it, know what's been going on, and for those who've been engaged, to be able to continue to engage in the conversation. So for those that have not been following, why the heck not? Shame on you. The Phenotype February has been our community activity that we kicked off on February 1st. We are now on 2/22/2022, which means we've made it through 21 days thus far, and we're on our 22nd day of taking a given phenotype every day and starting a community conversation about what is the clinical idea that we're targeting and what is the phenotype that we need to develop to study it. So we've kicked off now 21 different conversations that have led us to great conversations, both on how do we actually create a phenotype that could be used for a particular question, but also getting at some of the fundamental scientific issues about how we actually go through the phenotype development and evaluation process. Craig already posted that if you haven't kept up with all the conversations yet, you can see one-stop shop at odyssey.org/Phenotype February, which is providing the links each time we start one of these conversations. To reinforce the idea that these are the starts of conversations that we hope that everybody will engage in and continue on. So if you missed a day, you haven't missed anything. Please just go read the discussion and join in the conversation. And it's fun to see so many parallel conversations going on, and I hope that more will join in and engage in this. How can you get involved? So everything's happening out on our Odyssey forums at forums.odyssey.org. For those of you who are in our Odyssey Teams environment and wondering, like, where is it there? Craig's been posting on the general channel just to provide you links out, but we purposely chose to put it out on the Odyssey forums because that information is being indexed by Google and hopefully will become valuable resources as people are using this in the external environment more broadly. So encourage you to go out to forums.odyssey to read and post and respond. Really, the way to get involved is read and respond. That's what we're looking for. For those of you who have have access to data, you can also evaluate definitions by running the definitions that have been shared on your data and sharing it. We've been making the cohort definitions that have been developed in Atlas. We've made them accessible on a public Atlas-phenotype instance. And we are also making available results of evaluations on selected databases out on data.odyssey.org. We have now volunteers for all 28 days in February, so thank you all who have led and decided to engage in the conversation. It's great to see so many people participating. But if you feel left out and you want to lead a conversation, there's nothing to say that we can only do 28 phenotypes in Phenotype February. Feel free to engage and join another conversation and lead your own. And hopefully phenotyping won't stop in the month of February, but hopefully this is really just a kickstart, an activity that we all should engage in throughout the rest of our research. Highlighting, reinforcing again, if you're looking for phenotypes that we've created, most of them have been posted out at atlas-phenotype.odyssey.org, and you can check that out. You can get access to that. Those that have been run on selected databases and results have been shared have been posted at data.odyssey.org/Phenotype February. So if you're looking to see cohort diagnostics in action, you can see it there. And for those of you who'd like to run this study, you can go out to github.com/Odyssey Studies/Phenotype February. And Gowtham Rao and Azza Shaoibi have been leading our phenotype development evaluation work group. They had another session just last week, and will continue to provide support for those that are interested in engaging in these activities. So where are we at? We are now in week 3 of Phenotype February, which means you're going to get to hear today about acute myocardial infarction, heart failure, cardiomyopathy, multiple sclerosis, triple-negative breast cancer, multiple pulmonary hypertension, and prostate cancer as the areas that we initiated conversations just this week on. So I have a special thank you to Gowtham, Azza, Adam, Evan, and Asieh, who've initiated these discussions and are here to share some of their fun facts. We have the rest of the month already outlined, and I'll highlight that in just a second. But I want to right now focus on these specific discussions that we've initiated for these various diseases and ask those that have led those conversations to share their insights and fun facts. While we do that, We're going to post again a link out to pollev.com/Patrick Ryan 800. I think Craig's going to just paste that link in the chat for those of you who don't see it. But we want to hear from all of you about fun Phenotype February fun facts you've heard so far. And so we started this last week, getting folks to share some of their insights. You'll see that those insights and lessons learned are still there in the chat. But as you've been reflecting on what you've learned from the past 21 days of conversations about phenotyping, it would be great for you to post in your own insights. Or if you see something that sounds good and interesting, feel free to upvote it in this list. And so please do go share your insights, and we'll go look at that in just a few minutes. So I'm going to turn it over to all of our leads for this week. Ask them to just share a brief insight about the phenotype that they initiated and a key fun fact that they discovered. I'll start here with Gowtham from day 15, acute myocardial infarction.
Oh, this phenotype has given me a lot of chest pain. It is difficult. It is difficult. The work is not done, so I think I'm going to continue to work on this. It's very interesting for me that some of these phenotypes, even though there's been a lot of scientific work done, I found that there is no good cohort definitions out there that we can use. So there's a lot of opportunity to build on, and that's just my insight that I wanted to share. So please, for this particular one, please join us at the Phenotype Development Evaluation Work Group. I'd like to use the work group's time to collaboratively develop these clinical ideas and have some robust core definitions.
Very good. Thank you, Gowtham. Yeah, and I think specifically the thing that I think Gowtham tried to do a nice job here on the forums is highlighting the different subtypes of MI and asking the question, to what extent do we think that those subtypes are relevant and something that we need to be phenotyping specifically. There's tons of literature showing how people have defined MI at large. But I think Gowtham's asking the tough question about whether or not we need to be able to do better by being more specific for the subtypes that can be represented for this clinical idea. Then Gowtham, you started a conversation on heart failure on day 16. Share insights and fun facts there.
Same general idea. Again, this one has given me shortness of breath. So please, this is an opportunity to further evolve this clinical idea. I have lots more work to do on this one.
Very good. Yeah, so for those of you who have done prior work in heart failure, it'd really be great to particularly get insights here on the clinical definition of what we're targeting. There's a constellations of different diseases that are represented here in heart failure. And I think as we've seen past studies done, very often heart failure is used as kind of a crude proxy of something else, particularly if we think about like a hard outcome being something like heart failure related hospitalization, which is more of an acute episodic event versus the chronic disease status of heart failure that is sometimes what we want to represent. So having others join in and thinking about how we collectively can develop a phenotype for you would be quite helpful. And then Gowtham, and ending up your 4-day run of cardiovascular diseases, you try to tackle cardiomyopathy. You want to share insights and fun facts there?
Yeah. So so my understanding of cardiomyopathy is the cardiomyopathy has not been cardiomyopathy the way we think about it in the past. So that the contemporary definitions of cardiomyopathy is different from historical definitions of cardiomyopathy, and that's important because these days, in the last few years, we have the hypertrophic cardiomyopathy, restrictive cardiomyopathy, and the dilated cardiomyopathy. But in the past, there has been various other subtypes. Plus, what we learned is even though there is certain clinical ideas described in practice, it's not the people when the clinicians call somebody to have cardiomyopathy, they don't mean the same thing. For example, ischemic cardiomyopathy. In some contexts, ischemic cardiomyopathy is not considered cardiomyopathy, and so on and so forth. So there's a lot of variables here, and the biggest insight for me is this is not a one-day activity. This is the beginning of the story.
Very good. Yeah, I think in this one of the things that Gowtham shared that I thought was interesting is he fixated on talking about all the different subtypes, and then we looked at the data, and 70% of the records we have are just coded at the non-specific level of cardiomyopathy. So thinking about how we reconcile clinical precision with the broad strokes of what actually exists in data can be an interesting challenge for us to think about, not just for this specific cardiomyopathy example, but as a broad problem that we need to think about for many different phenotypes. All right, and then Azza stole Gowtham's account and prevented him from posting something and started a different conversation on day 18 about multiple sclerosis. Azza, can you share your insights and fun facts from that?
Yeah, I think I got two insights after working or starting the conversation on multiple sclerosis. One is that multiple sclerosis, like some other disease, is a disease that can start and then either go in remission or can have relapse. So it goes in different stages for different patients. And when we try to phenotype, one question we might want to answer is what kind of multiple sclerosis patient we are modeling, or at least think that there might be more than one model, and which is the right one that represents the disease itself for the most part. An initial onset of multiple sclerosis is one kind of patient. A patient with multiple sclerosis in remission is another patient. A multiple sclerosis with relapse is another kind of patient. So these are things that might manifest differently in the data. In some cases, we have codes that can indicate something versus the other. In many cases, we don't, and we have to rely on some logic and so forth. So that kind of thinking is something that I realize in multiple sclerosis that it's important to kind of understand these situations. The other insight is multiple sclerosis. There's a lot of literature that talks about the no specificity of observational definitions for multiple sclerosis, or like the claims of the codes used for claims might have low specificity because the disease takes long to be diagnosed, and so the code might be used for ruling out purposes. And what I learned is that there is this general idea about codes in observational data having low specificity. However, it's really not one situation that covers everything. It's not the same for diabetes. It's not the same. Like, we really need to understand the specific situation we're dealing with and not have one rule that goes for all codes have low specificity or all codes have low sensitivity. You have to understand literature can be helpful in this situation. But the more important part of this, my insight was there are different approaches to improve specificity of a definition, and there is no one solution that's going to work for all the situations. So in the US literature, there's a lot of this idea of using multiple diagnosis codes to improve the specificity. But if you take it and apply this across all data sources, you might actually get to worse situation. So really to think that what an approach to improve specificity for one disease in one data source at some point in time is not true for another database in some other time and for other circumstances. So think about this very thoroughly when you're starting to phenotype.
Very good. And I'd say don't just think about it, empirically test it rather than making assumptions. So all of you out there who were just told in your intro to database informatics class to just do 2 or more diagnosis or one in an inpatient setting, we need to brainwash you from that silly rule, because it is not a one size fits all at all. Very good. Thank you, Azza. Day 19, Adam took the reins and initiated a conversation on triple negative breast cancer. Adam, what were your insights and fun facts from that?
Yeah, so my fun fact is don't use the concept for triple negative breast cancer to find triple negative breast cancer only. Although it basically, my cancer is difficult, and I had a lot of similar thoughts to what Azza was just mentioning, that you need you really need access to the data and be able to test your cohort definition, and it's really tied up with the type of data you have and the vocabulary as well. What measurements values, what measurements were used to capture the ER negative status, PR negative status, and HER2 negative status. So yeah, I think I just scratched the surface with this one, and I think for cancer, some of the discussions I had with Asieh are we look for an index on a condition and then also look for like a biopsy or a measurement within some range of that to try and get a good index for cancer. But yeah, I learned a lot, and thank you.
Great, thanks, Adam. I think you did a great job of actually showing a nice demonstration of creative ways to think about that trade-off of sensitivity and specificity when using multiple measurement markers for the estrogen receptor, progesterone receptor, and HER2 receptor. You showed how you could either think about requiring that you observe them to be negative, or requiring that you can't observe them to be positive, or what happens if you don't do it at all. And I think that that's a nice rubric to think about when you need to integrate a broad diagnosis, in this case of all breast cancers, with additional information to help us get more down into the specific subtype. So encourage people to join Adam in the conversation of triple negative breast cancer here.
Hey, Adam, this is Thomas. How many of the patients in your cohort had the measurements? So it seems like the two conditions were a condition and a biopsy. How many of those patients actually had indications of measurements?
Well, I only had really limited data to look at this, but so I don't have the number off the top of my head, but it was smaller. It was, it dramatically reduced the cohort size to require those measurements, especially the measurement values. So that's why I went the other direction of just requiring that they had a measurement and did not have a positive measurement, as well as had no drugs that that indicated that they were ER positive or estrogen receptor positive. So it had a big impact, yeah.
All right. Day 20, we got to the weekend, and Evan started us off on a conversation, finally putting the PH in Phenotype February with a discussion, a very extensive clinical description of pulmonary hypertension. Evan, as you went through this, please share any insights and fun facts that you came across.
Well, I think it just came across there. I just put in a link that demonstrated demonstrates the classification of pulmonary hypertension that actually the WHO has maintained or created some really meaningful distinctions that are often used at the bedside. And one of the things I found kind of fascinating, this is a bit of a prelude to the discussion that's going to be coming, is if you actually look at the ICD and most recent version, ICD-10 that's in deployment, those distinctions that are really maintained by the WHO don't quite make it into the terminology. And I thought that was quite interesting. It's not in every disease where you see the WHO using creating a classification system that's used at the bedside, and it kind of highlights the constraints that the terminology is under in terms of its evolution to incorporate the cutting edge distinctions within a particular disease. And I think Claire last week mentioned the constraints that the CDM is under sometimes in terms of how it evolves. You can imagine how much harder that is, in a system where your main vehicle for counting things is the terminology itself. It winds up being fairly constrained in terms of the way it evolves. So I thought that was an interesting fact. And one of the things that it led me to start thinking about more is just the need for broader feature generation. And Paul, I feel bad. I didn't go into the different imaging characteristics you can see, but they're certainly there. I know. And as a card-carrying medical physicist, I feel a lot of shame right now. But there, I think the potential for things in imaging, echocardiography, which often has very structured reports that could be really amenable to feature generation, EKG. I think there'd be a lot of interesting things that we could look at because the source terminologies are going to be a bit challenging in this space.
That's great. And I think, Evan, your highlight about the fact that the coding designation doesn't actually meet up with the subtypes is also part of the generic explanation for why we see subtypes of diseases get coded at higher level constructs, is because if you're only left with the incompatible constructs, you kind of have to pick the thing that's non-specific just to represent the idea that you have in your head. And we see that play out in a lot of situations where, in hindsight, we look back at the data and start wondering, like, why did clinicians code it this way? And you're pointing out, like, maybe because that's actually the best and most appropriate thing that could be done given the constraints that existed in the system. It
also shows what a massive asset the terminology effort is in Odyssey, I think, because in looking at those, and that's another prelude, is that there's a much better alignment with those clinical ideas, and just as more systems, I think, kind of realize the power of the terminologies to help them, manage those changes in the underlying source vocabulary. I think they'll see what a gift that is to medical informatics community as a whole.
Very good. All right, so certainly encourage you to join Evan in the journey on pulmonary hypertension. Then just yesterday, day 21, Asieh started us on a discussion of phenotyping prostate cancer, and both sharing some of the work that had been previously done within the IMI Pioneer project, but also exposing some new insights. So Asieh, you want to share some insights and fun facts with the group?
Sure. So I'm just going to put them together. I think, like, generally when I'm thinking about it, it's never getting boring. And the more you do it, the more you learn about all these nuances and details. Some of them, like Adam's talked about, that you have to consider. And so, like, day one of the conversation, it was one question, and now, like, there is a list of questions that we have to think about. And the more you do, the more questions you know, and the better you get to understand the difficulty and all the challenges that phenotyping has. But I think that's not possible with the power of the community. Like, everything that we can get from the clinical expertise and experience, from all the insight that we can learn from the databases and the expertise that the data, like, and the vocabulary and everything is the only way to make it possible, which kind of highlights the importance of clear description of a specific phenotype, which is pretty much lacking in the literature. But on the other side, the other good part was, don't forget about the data, the power of the data, and how we can do some empirical assessment. I had a lot of fun, but I had to stop at some point not to get too much into that. Yeah, and then let's make it better. I don't think we're done there.
Very good. Yeah, Asieh did a really nice example of how you can actually let the data tell you about co-occurrence of elements to give you an empirical basis to make some of the decisions that all too often we see kind of get arbitrarily made by someone saying, oh, it's a 30-day window, instead of actually looking at what does the data actually tell us should be the window, which I think is a really powerful tool that we all can take advantage of. So if you're interested in prostate cancer, please join Asieh in this conversation that just kicked off yesterday. So just to give you a sneak preview of what's coming up for the rest of the week, you're going to get to learn about HIV, hidradenitis suppurativa, anaphylaxis, depression, non-small cell lung cancer, drug-induced liver injury, and developmental disabilities, plus any other conversations that you all want to kick off during Phenotype February. I encourage you to do that, to join any of these 28 conversations as they kick off, or initiate your own. The main thing that we're trying to do is, one, hopefully get to the point where we've got some phenotypes we can trust for these diseases, but also try to make sure that we're evolving the science of how to do phenotype development evaluation and start to evolve towards having recommended practices that we can all follow to do a better job of creating more important, or more evaluated and potentially valid definitions. So I'm going to switch over to our pollev.com/PatrickRyan800. Encourage you all to be entering stuff in. I'm going to see if I can drag it over to the screen, and let's see what you guys are thinking about here. All right. Let's see. Is that active? Are other people voting on this? I just want to make sure I got the right thing up. Hopefully you guys are seeing it. All right. So I'm seeing that clarifying the clinical idea in the description matters. This is something that we captured before. That Gowtham works early in the morning. Interesting to see how people are approaching the same clinical question in different ways, and this is the reason why our community is so important and essential. Actually, I've enjoyed reading the posts and learning from different perspectives, but also seeing some of the the discussions and disagreements, I think, are actually helping us evolve our thinking. So I think that's definitely a good point. I commit not to look at codes before. Where did I jump? There we go. I commit not to look at codes before writing a clinical description. That clinical description is the most important first step for phenotyping. So something jumped up here. I learned through the power of the community feedback from others in the Odyssey. Improved my my cohort algorithms. And it's a lot of work. Someone just said that. I think that person saying I'm tired just reading it, but I'm also convinced that it is so important. And it never gets boring. The more that you work on a phenotype, the more you learn and the better it gets. Very good. So I want to thank everybody who's been participating in these conversations, particularly thank Gowtham, Azza, Adam, Evan, Asieh for your leadership in this week's conversations. I want to encourage everybody to really do take the time to read and learn from the insights that the community shared and to join and contribute to these conversations. I think there's a lot to learn, but there's also a lot more that we can be doing together to work on this. So encourage you to take advantage of this through the rest of Phenotype February. And with that, I'll stop, Craig, and hand it back to you.
Yeah, I know we're at the end of the hour here, so thank you to everybody. Again, I just posted the link to Phenotype February. I meant to mention this before. If you go to the one on the 14th, hypertension, Gowtham actually did a video of kind of his thought process throughout and how he came up with it. And it's actually really cool. And, it's not just, text. It's actually kind of why he chose certain decisions. And, it's good about the thought process, too. And I thought it was really cool that he made it. And I know Ned Gowtham doesn't love making videos. So I appreciated the fact that he did it. And I think you can learn from it. And think other people have the opportunity to do things like that. So thank you to Gowtham for doing that. But it's been a great activity. We have another week to go. We have some great breakouts next week, discussions to have. So a lot to be excited about. Again, October 14th to 16th, put it on your calendars now. We'll have more information as we go. Thanks, everybody. Have a great day and a great week. Happy to whatever day.